Morning friends, I am Arun Kakar. I was a professor of surgery in Malanzad Medical College. Retired in 2012 and has been fortunate enough to be with you guys who are doing DNB in general surgery and at times some of the CMEs who interacting with you young folks who would be doing post-graduation in surgery. It's sad that some of you are jumping straight into super specialties like neurosurgery, cardiac surgery, or urology without doing general surgery. It's my personal opinion, I may be wrong, that to be a complete surgeon, irrespective of which part of the body you are specializing in, you have to have a broad outlook about all the system, and that can be covered only if you do a general surgery. I think the good old tradition that you do general surgery, you do a senior residency for a year or two and then go into super specialty had a merit, and I still think it has a merit, rather than do your MBBS, do internship and then get into a 5 years of super specialty, whichever you want to. Because there are few things which are not dealt in that super specialty. That's my experience. Of course, I may be wrong. But I know in the hearts of hearts, many of you who have not done a general surgery would realize that it does make a difference. For example, you're doing a urology. You get a case of urological problem and the person has an associated peripheral vascular disease. How many of you would be able to clinically evaluate that patient? You would straight away request your colleagues in general surgery or in vascular surgery. In a way, you may be right, but don't you think it is necessary that we should know how to evaluate the peripheral pulsations, how to record a history? A person who's come to you with a kidney problem doesn't mean that he can't have associated gastrointestinal or a vascular or a pulmonary problem. We have divided the body into various segments. And similarly, unfortunately, we, including so-called faculty, had divided our brains into various segments. That my brain will only be handling urology. B person's brain would be only handling neurosurgery. That doesn't work out. I'm afraid that's not true. It's not rare that sometimes the general surgeon is called to put a insert a Foley's catheter in a 55-year or 60-year-old man who has undergone a craniotomy. Why? Because the neurosurgeon doesn't have enough experience. Taking that as a background, I think it's important to know how to evaluate a person who comes to you with a peripheral vascular disease. And the common peripheral vascular diseases that you come across are thromboid angiitis obliterans in the lower limbs, atherosclerosis, and in the upper limb is vasospastic disorders like Raynaud's, phenomena or Raynaud's disease, or ischemia in the upper limb due to scalenus anticus syndrome or cervical rib. And of course, embolus can occur anywhere, more often in the lower limb than in the upper limb. When a patient comes with a chronic ischemia, though classically Burgess involves lower limb, but upper limbs are not rare. So, in the evaluation, after having taken a history, and amongst irrespective of whether it is chronic atherosclerosis or it is a Burgess disease or is a vasospastic disorders, one of the things that must be asked from a person is history of smoking. That is possibly the contributing factor in large percentage of cases. So, in history, in addition to taking the history of claudication, the claudication distance, the rest pain, etc., it is relevant to take a history of smoking, diabetes, drug abuse, any previous surgery, having done that, when it comes to do clinical evaluation, besides the general physical examination, you have to examine the pulsations. Whether the person has come to you with a disease involving the lower lip, or the young lady has come to you with a ischemia of the fingers. Overall evaluation is a necessity. One of the other conditions which is not common, fortunately, is arteriovenous fistulas. Even there you have to do the same examination. So, today we are going to concentrate on how to examine the pulsations in a patient who comes with the Burgess disease. You first examine the lower limb pulsations, and a young lady who comes to you with a Raynaud's or feature suggestive cervical rib or scalenus anticus syndrome, you have to examine the pulsations of the upper limb. Whenever there is a chronic ischemia, the examination of heart is also important. Agreed, as a general surgeon, we are not expected to know S1 and S2, but we are expected to know if there is a gross cardiomegaly, or if there are gross murmurs, or there are features of cardiac failure. While leaving those aside, we'll be focusing only today about examination of various pulsations in the upper limb and the lower limb. Since vasospastic disorders more often involve lower limbs, we'll start with examination of pulsations of the lower limb. Later. Like a basic principle of physical examination as inspection, palpation, percussion and auscultation. Of course, there is no question of percussion, but inspection is very important. Before you examine the pulsations, you look for signs of chronic ischemia or an acute ischemia. Acute ischemia is quite obvious. The limb is pale. You will find that the veins are collapsed. The chronic ischemia is sometimes, if you are not careful, you may miss. And the evidences are, if you remember the first structure to suffer a blood supply is the skin. And the evidence that a person has been having a chronic ischemia, the skin manifestations are, you would see that there is loss of hair or there are sparse hair. There is atrophy of the skin. This is a healthy skin. Atrophy of the skin. There are changes in the nails. You might find that if you elevate the limb a little bit, the veins, because the blood arterial flow is decreased, the venous return is decreased, and you get a gutter-like appearance along the course of long saphenous vein. Might see tapering of tips of digits, might see absence of sweating, absence of subcutaneous fat, and having done inspection, you might see that the limb which is affected between the normal and abnormal, the skin temperature changes. The limb which is undergoing or has undergone chronic arterial insufficiency would be colder compared to the normal skin. If it is secondary to diabetes, may have loss of sensation because of neuropathy. So, inspection is over, the palpation is over. As a part of palpation is examination of various pulsations. In the lower limb, the first pulsation is you palpate for the femoral artery, and we all know femoral artery is nothing but a continuation of external iliac artery, and is best felt in the femoral triangle just below the midinguinal point. The best way to palpate the femoral artery is gently flex the knee and hip a little bit, externally rotate it, and then you palpate the pulsations of femoral artery against the head of femur. Normally, femur is within the acetabulum. So, to make it better, we externally flex it and externally rotate the hip joint so that the head comes out a little bit from the acetabulum, and you can palpate the pulsations of femoral artery. This is what is also called as common femoral artery, and you can palpate both sides at the same time. It's better if you complete on one side and then you do it on the other side. Having done the femoral artery, it continues beyond the adductor canal as a popliteal artery. And in the lower limb, one of the most difficult pulsation is feeling for the popliteal artery. Popliteal artery is situated in the middle of popliteal fossa and is felt best against the condyles of the tibia. Mind you, popliteal artery is not felt against the medial or lateral condyle of the femur or the epicondyle. It is palpated against the condyle of the tibia.